Welcome to QD Clinic. Hi, I'm Jack Cush with Room Now. Room Now is going to be bringing you our expanded coverage of ACR 2021, the Convergence meeting, all virtual in the comfort of your own home and fuzzy slippers. But we'll be there. You're going to see a lot of interviews, a lot of panel discussions, a lot of great tweets. You can follow us on Twitter. Hope you're around to see what we do. Today's case is the thyroid lump. And I use the term lump, could be a mass, could mean that I'm lumping thyroid with other things, could mean it's to kind of indiscriminately put things together. And that's really what happens with thyroid disease and what I'm going to describe. A 56-year-old woman is not feeling good, having fatigue, some hip pain. She's a bicyclist, not sure why that's going on, goes to primary care, and ANA is done. Sort of like that's where all stories start to go bad, huh? Well, the ANA comes back positive, 1 to 160 in a speckled pattern. That leads to a rheumatology consult. That leads to a lot of testing. That leads to a trial of hydroxychloroquine and pain medicines. That leads to a call to me. Should have called me to begin with, because, it should have led to a bunch of questions like, could this be lupus? Because there's really not much else in the story for lupus. But again, fatigue, a little bit of joint pain, monoarticular, large joint, one hip, unlikely to be lupus. But, other things that you'd go down and make sure it's lupus. And is this early undifferentiated lupus? No, this is, aches and pains, maybe from other reasons like sleep and depression or God knows what, but certainly not lupus. And of course, the woman has a history of Hashimoto's thyroiditis and is on Thyroid and is currently suboptimal in her Thyroid dosing. And she doesn't want to take so much. She'd rather feel this way. Maybe feeling this way is the joint and fatigue stuff. So I want to remind you of some of the numbers on thyroid disease and autoantibodies. It's actually much higher than you think. Up to 80% of patients who have acute or chronic thyroid disease are going to have a positive ANA. It's kind of shocking. And that number goes higher. It starts at a low of about 33%. Maybe the youngest people, the healthiest people, uncertain diagnosis, new diagnosis, it might be as low as 30. But as you get older and older, it goes as high as 80%. As you go older, so does the frequency of the totally useless anti-thyroid peroxidase antibodies. I don't think that really cinches any diagnosis, to be honest with you, but it adds to the picture. And there's a multiplicity of autoantibodies directed at thyroid antigens, not unlike what we see with other autoimmune disease. So age plays a role, actually having thyroid disease. And I think thyroid disease is a little bit like Sjogren's, meaning an autoimmune attack on a gland that when it's done, the gland is destroyed, doesn't work well again, and you have to use replacement therapy. Am I not describing Sjogren's here? For which, by the way, that autoimmune attack, that inflammatory attack, doesn't need further immune suppression or inflammatory control. But you're dealing with the consequences of a dysfunctional, hypofunctioning gland after the immune activity. So the interesting thing is a few things. One, that this is more frequent in women than in men. It increases with age. There's a co-association. Lupus patients and RA patients have a higher risk of thyroid disease. It's one of the more common comorbidities. Lupus patients don't usually get extra cancers, but when they do, thyroid cancer is probably the most leading cause of cancer in lupus patients, with a rate of about 25 to 30% of all the cancers in lupus patients when that does occur. That thyroid disease is actually also more common in RA patients than in controls. In this one study, 16% versus 11%. So overall, RA and thyroid patients have a twofold risk of thyroid disease. But thyroid patients themselves have autoantibodies and conversely a low risk of RA and SLE. But those should be easy for you to diagnose when that happens and if that happens. Otherwise, there's no sense in treating a blood test. Interestingly, I think I know it's been shown for RA, but I'm not sure if it's been shown in lupus that the offspring of RA patients are also more likely to have thyroid disease. And then lastly, as you know, many autoimmune phenomena occur as a result of immune checkpoint inhibitor therapy for like melanoma, etc. And endocrinopathies are more common than are rheumatoid arthritis and PMR. And hypophysitis leads the way, and probably next most common is thyroid disease, with ultimately manifesting as hypothyroid. So again, this association between thyroid and autoantibodies and autoantibodies from that maybe being associated with a higher risk of other autoimmune conditions needs to be carefully considered and understood by all clinicians, especially by rheumatologists. That's it. Check out our next QD clinic. Check out our coverage of ACR 2021.